Good afternoon, everybody, and welcome to another version of IPC Partners Journal Club. I'm delighted to welcome Alastair today. Alastair is going to be talking to us about a really exciting project that he's been working on for some time. And I'll do a little introduction to Alastair in a moment. And Alastair is going to cover this paper here, What's Needed to Sustain Improvements in Hospital Practice Post-COVID-19, a qualitative study of interprofessional dissonance in hospital infection prevention and control. So just before I introduce Alastair formally, we always like to talk a little bit about what IPC Partners Journal Club is designed to do. We like to bring on special guests, so I'm delighted to have Alastair on today. Ideally, we're trying to provide some insight into a topical IPC published paper, and really we'd want to try and generate discussion. So you've got a really important role in the audience today to ask questions. So please use the Q&A box that you can see at the top of your screens in Teams to ask Alastair or me any questions that you might have, or share your own opinions and perceptions. We'd like it to try and think we're doing a bit of critical thinking as well, talking about how we analyse some of these papers. And ideally, we want us to be able to have a little bit of fun. So hopefully we can do that as well. We always record these journal clubs. You're all muted and your cameras are off, so you can't be seen. But we do then upload the recordings to our YouTube channel to just grow that education for people who might not be able to attend. So yeah, without further ado, I'll just introduce Alastair and read Alastair's biography. So Alastair Rzeznicki is a storyteller, video producer and creative specialist who completed a degree in content creation for broadcasting and new media in 2005. His dissertation explored how creative thinking could be applied to the challenges of IPC, and it was during this research that Mrs. Jell and Friends Bringing Fun to Infection Prevention was born, inspired part by the emotional reality that too many families, including Alastair's own, have experienced loss due to preventable infections. And drawing on 25 years of community-focused media production and a background in creative problem solving, Alastair is going to explore how IPC teams can reimagine education, borrowing proven approaches from other sectors, tapping into emotion, behaviour science and storytelling, and ultimately shift how people feel, learn and act around infection prevention. And I think those things really resonate with me, having worked in IPC for a long period of time. I'm really interested in how we influence people's behaviour. And I think Alastair's going to give a really interesting perception about how we might be able to do that. So Alastair, I'm going to stop sharing my screen and I'm going to hand over to you, and I'll see you back for the Q&A.
Okay, thanks, Phil. Okay, so I'm hoping that everyone can see that. I imagine Phil will tell me.
I'm checking and we can see it, Alastair, so you're good to go.
Okay, well, first of all, thanks to yourself, Phil, and John for this opportunity to spend some time with you all. Like Phil said, I'm first thing to say is I've got no medical background per se. I'm someone who became very interested in infection prevention when I was around 17. My gran, I've got a photo here, it was on my wall. I'm not sure how well you can see that, but there's my gran and myself at 16, 26 years ago now. She contracted MRSA when she was in hospital, and she sadly passed away. And when I went to university to do my degree in television, I got to my dissertation and I thought, do you know what? All of the coverage in the press is very negative, and if we spent as much time educating the public about what they could do from an infection prevention point of view when they go to visit loved ones, we'd probably be much further forward. So I wrote my dissertation all about that concept and looked at how I could bring creativity to some of the problems. And from that, Mrs. Jell and Friends was born. My university gave me a £5,000 grant, and we developed some cartoon characters and worked with 2 local hospitals to put together some resources to help them reduce infections. Before I go into that too specifically, today I'm going to cover a little bit more about Mrs. Jell and Friends, bringing fun to infection prevention. Talk briefly about Hans Zimmer. Some of you may know him. He's the Oscar-winning musician, and this concept around Doris. He writes his music for what he calls Doris. Then I'll look at the study, which is, you can see the title there, What is Needed to Sustain Improvements in Hospital Practices Post-COVID-19. I'll talk a little bit about how I use AI to move through that information. And then we're going to look at some of the opportunities around the concept of glass being half empty and half full. And then I've done some work previously in digital inclusion, and there's a recent digital inclusion action plan that the government published, and it would be good to spend some time with all of us thinking about ideas that could go into an infection prevention plan, predominantly focused on supporting continued public education to make them a partner in infection prevention reduction when they visit loved ones. So that's what we're going to do. Top right-hand corner is the very first Mrs. Gel character. It was based on a helicopter, a flying hand gel bottle. I was actually working as a helicopter cameraman straight out of university, flying around filming war game exercises with the military. So that was happening at the time. I was thinking a lot about infection prevention, and specifically, I kept asking myself this question over the last 20 years: what is it I can learn and know, and what could I have learned and known at the time when my gran was in hospital, so that I wasn't one of the people potentially spreading infections. So I've got a short video here that introduces some of the work we did 20 years ago in the local school in Brighton.
I don't know if anyone's ever going to see this. And no tips lessons are coming to anything. So I've taken that notion of creating this project in the hope that possibly one day someone's grandmother or grandfather or brother or sister or mother or father will not get an infection which leads to a fatality because of the knowledge of my workshop and my idea has brought to them. And so even if we just educate these 30 children, although I believe with what we've got, we will go on to educate a lot more, we've actually created something pretty amazing, if I must say so myself. Because as I sat here 6 months ago on this couch and said, how do I have an effect on society? How am I going to do it? How do I have a positive influence? Tomorrow we do it. We may do it on a minute scale, but we are teaching 30 people 5 things they don't know, 5 things which potentially could save however many lives.
Safe workshop. We're going to be using UV light boxes to see how well you can cut off.
I've got this ill guy that you shouldn't really go into a hospital when you're ill. He's sneezing without a tissue. He hasn't washed his hands. He hasn't washed them very well. He's picking his nose, as you said.
Did you know those things before, though? Very good. So you'll remember that?
Yeah. My nose is in hospital at the moment. So.
You know?
Yeah.
Oh, so this will be good practice.
Yeah.
Okay, so back in 2005 down in Brighton, it would actually be really good if we could go back to that school and see if they could actually get in touch with those students to see actually whether they retained any of that and had any information that was useful during the pandemic. I think that'd be a good little project. So over the last 20 years, like I said, this has been a side project alongside having a career in television and film. It has had some various coverage in papers like The Guardian. And during the pandemic, we spent a lot of time utilising the cartoon characters to promote public health messages to as many audiences as possible across social, and essentially just giving away the content as widely as possible to help with what the government needed everyone to do, but in a family-friendly delivery format. So the brand has grown over the years in terms of there's about 30 characters now, trying to open up a whole world. And if you've ever wondered what hand gel bottles get up to when no one's looking, this will show you. Okay, so in 2005, I chose cartoon characters as the IPC communications vessel, as they're effective because they leverage human psychology, capture attention, and build emotional connections, and can simplify complex information in memorable ways. Okay, so Hans Zimmer, known for the Gladiator soundtrack, Interstellar, The Lion King, he says that he doesn't write his music for the director or even the movie studio, but rather a made-up figure called Doris. And he imagines that she's a single mum, she works really hard, she has a choice on the weekend. She can either go to the pub or see a movie. If she goes to see the movie and I've done the music for it, I better give her 2 hours of an experience, 2 hours of reprieve. To this day, when I write, I sit there and I think, what would Doris think about this one? And I just wonder, you know, does IPC work backwards from such a concept? I certainly do that in my production world and with Mrs. Jell and Friends. And I think it's an interesting question, that concept of working backwards from the end user. Okay, so it was a bit scary thinking about a study to choose, because I've watched a few of these webinars and it's full of really intelligent people talking about, you know, really important things. And choosing a study and being asked to talk today was a bit like when you visit a hospital, when you're around healthcare professionals, you can feel very, you know, it's just a normal member of the public. You can feel intimidated because of the respect we have for the people who look after us. And choosing a study was no different. I went through quite a few. Anyway, so yeah, this study, I will read out the findings. So key findings from what is needed to sustain improvements in hospital practices post-COVID-19, a qualitative study of interprofessional dissonance in hospital infection prevention and control. So it's published 14th of April, 2022. They interviewed 26 senior clinicians, 16 doctors and 10 nurses, and it was a large Australian tertiary hospital. So the key findings were there were persistent stereotypes. Doctors were often seen as independent and sometimes dismissive of IPC rules, while nurses were described as rule-driven and inflexible. The doctor-nurse game, the classic dynamic where nurses must carefully navigate how they remind doctors about IPC, remains. If reminders are perceived as criticism, they may be ignored or provoke a negative response. Organisational barriers, staff redeployment, interrupted surveillance, and variable adherence were common, with some wards excelling and others lagging behind. Interprofessional attitudes and power dynamics hinder consistent IPC practice. The study found that before the COVID-19 pandemic, doctors and nurses held markedly different mindsets about infection prevention and control. Doctors were described as more self-directed, less inclined to follow rules rigidly, sometimes unaware or dismissive of IPC protocols, whereas nurses were depicted as rule-following, often feeling obliged to enforce or remind others of IPC standards. This dynamic created friction and reduced the consistency of IPC practice. For instance, nurses felt constrained in reminding doctors of lapses, and doctors resisted being supervised by nurses. The authors frame this as a continuation of the doctor-nurse game of power dynamics in healthcare. The implication, any sustained improvement in hospital IPC requires addressing these issues underlying interprofessional relationships, not just the protocols or checklist items. The final slide of reading the text. The COVID-19 context created momentum, but sustainability demands embedding change into context. The authors argue that the heightened awareness, shared threat, and urgency brought by COVID-19 created a rare moment of interprofessional focus on IPC. They suggest that this common threat offered a unique opportunity for unity and behavioural change. However, they caution that post-pandemic, the challenge will be how to convert that temporary surge into long-term routine practice environments. They emphasise that implementation of IPC policies must not just be top-down, one-size-fits-all documents. They must be context-aware, respect the expertise and work practices of different professional groups, and integrate into everyday workflows. Okay. Oh, final one. Sorry. Hold one back. Right, an ethical, inclusive framework for interprofessional collaboration is needed. A key takeaway is that the authors propose using an ethical framework to guide collaboration between professional groups. They note that many failures in IPC stem not from the lack of knowledge, but from missed opportunities to engage people's professional identity, power relations, accountability for patients and colleagues. They highlight that to sustain improvements, you need to recognise and respect professional roles and expertise, doctors, nurses, allied staff, foster open communication and flatten hierarchies so that all staff feel empowered to speak up about breaches or concerns, align organisational policies with frontline realities so rules are workable, not just idealised, keep moral purpose visible, i.e. emphasise patient safety, collective responsibility, rather than only regulatory compliance framing. Right, okay, so I got through that. I did read that study, but I got through that by using what, 115 to 180 million people use a day. I used AI. I put it in and I said, can you please summarize this? Because I'm a member of the public. And that's, a big daunting thing to come across and to try to dissect. So I asked ChatGPT to dissect it. And it gave me these 3 bits that it said were the takeaways. I read those and I said, give it to me in 3 lines. Not because I didn't understand those, but I just wanted the core information. And then I said, visualize it. I want to see that those takeaways in a visual form so that I can understand it. And it came up with this image, and that whole thing took about, I don't know, 40 seconds to do that. So that one study left me with an impression of why infection prevention breaks down between healthcare teams based upon that specific survey in that hospital at that time. Doctors being self-directed, less rule-orientated, power dynamics, reduced speaking up, nurses rule following, unity because of this global problem, and then the recommendations, need for ethical collaborative culture, which presumably COVID brought out in people in a way it might not normally. So that's what I did to try to understand that. As I would with many problems in life, I try to use tools, technological tools to help me. Okay. So I don't know what your feelings are about this, and I'm sure we'll talk about them at the end. But as a non-medical professional, I was left feeling with a negative impression of IPC in healthcare settings. That is not necessarily true everywhere, but that's what I was left with. If I didn't know much about it and I came across that study, or that was on the news or in a report or on social, I'd be thinking, if that was an aeroplane and I knew there was disharmony on safety between cabin crew and pilot crew, I ain't getting on it, So, with someone with a big passion for infection prevention, I was left with the question of, how would the findings in this diagram change if you added IPC educated patients and visitors watching these dynamics play out? So, for example, if I was in that hospital and I knew some of those dynamics and I was prepared to speak up, would those behaviours change? And how would it look if we had a more educated population off the back of COVID, with some of the challenges that go on in hospitals around these things when people are under pressure? Would the doctor nurse game be reduced, like during COVID, when the public were visibly demonstrating IPC efforts as well in front of healthcare workers? But overall, I was left feeling pretty negative about these findings. So it reminded me of this time when I was on an aeroplane.
You better get someone else.
Okay, so we're about 3 minutes away from Wheels Up, so you need to just stay put. Okay,
No,
you gotta hold
you
tight.
don't understand. I can't be sitting here. If something happens, we won't be able to get out.
Calm down, okay?
I cannot do it. I will panic.
All we need to know is that you're willing to assist passengers in the event of a non-traditional landing.
I cannot be of any help whatsoever in any kind of non-traditional landing or any traditional landing.
Okay, so I don't know if you've ever sat near those seats by the exits or on the wing. I was sat next to one time years ago on a flight, and the cabin crew member said, could I just ask you to lift up the window cover? And I said, yeah, sure. I said, can I ask why? And she said, yeah, if the engine catches on fire during takeoff, we need you to be able to tell us. And I was kind of obviously quite shocked by the answer, and a bit like Larry, You know, so we got Doris, we got Larry, and I was, you know, oh, but then also I was like, okay, this is kind of cool. I'm becoming part of the safety crew to a degree of that system, and so you know, I'm assuming there's harmony between the cabin crew and the pilots, and I'm now, you know, part of that triangle to keep people safe. So yeah, so look, you know, but the thing is, if we start with a negative IPC impression, or we only hear the negatives coming through, say, for example, the COVID inquiry reports, what then? And this got me thinking about, like, how do we consume information? And when we hear it and it's a negative, what happens in our brains?
Hi, everyone. I thought I would talk a little today about how people think. I'm fascinated by this question. I'm a social psychologist, which basically means I'm a professional people watcher. So this is what I do. I try to figure out how humans think and how we might be able to think better. And here's something I noticed a few years ago about how I seem to think. Here's a typical week in my life, which usually seems to revolve entirely around publishing papers. So here I am in the maximum of my artistic abilities as a stick figure, going along at baseline, and a paper gets accepted. I get this rush, this blip of happiness, and then I'm back to baseline by about lunchtime. A few days later, a paper might get rejected, and that feels pretty awful. And I wait for that blip to end, but somehow I just can't stop thinking about it. And here's the craziest part. Even if another paper gets accepted the next day, well, that's nice, but somehow I can't get that pesky rejection out of my head. So what is going on here? Why does a failure seem to stick in our minds so much longer than a success? Well, together with my colleague, Amber Boydston in the political science department, I started thinking about this question of, do our minds get stuck in the negatives? We all know intuitively that there are different ways of thinking about things. The same glass, the saying goes, can be seen as half full or half empty. And there's a lot of research in the social sciences showing that depending on how you describe the glass to people, as half full or half empty, it changes how they feel about it. So if you describe the glass as half full, this is called a gain frame because you're focusing on what's gained, then people like it. But if you describe the same glass as half empty, a loss frame, then people don't like it. But we wondered, what happens when you try to switch from thinking about it one way to thinking about it another way? Can people shift back and forth, or do they get stuck in one way of thinking about it? Does one of these labels, in other words, tend to stick more in the mind? Well, to investigate this question, we conducted a simple experiment. We told participants in our experiment about a new surgical procedure, and we randomly assigned them to one of two conditions. For participants in the first condition, the first group, we described the surgical procedure in terms of gains. We said it had a 70% success rate. And for participants in the second group, we described the procedure in terms of losses. We said it had a 30% failure rate. So it's the exact same procedure. We're just focusing people's attention on the part of the glass that's full or the part of the glass that's empty. Perhaps unsurprisingly, people like the procedure when it's described as having a 70% success rate, and they don't like it when it's described as having a 30% failure rate. But then we added a twist. We told participants in the first group, you know, you could think of this as a 30% failure rate. And now they don't like it anymore. They've changed their minds. And we told participants in the second group, you know, you could think of this as a 70% success rate. But unlike the first group, they stuck with their initial opinion. They seemed to be stuck in the initial loss frame that they saw at the beginning of the study. So notice what this means. Once the loss frame gets in there, it sticks. Well, at this point, we were getting curious. Why does this happen? Could it be that it's actually mentally harder for people to convert from losses to gains than it is for them to go from gains to losses? So we conducted a third study to test how easily people could convert from one frame to another. This time, we told participants, imagine there's been an outbreak of an unusual disease and 600 lives are at stake. And we asked participants in one group, if 100 lives are saved, how many will be lost? And we asked participants in the other group, if 100 lives are lost, how many will be saved? So everyone just has to calculate 600 minus 100 and come up with the answer of 500. But whereas people in one group have to convert from gains to losses in order to do that, people in the second group have to convert from losses to gains. We timed how long it took them to solve this simple math problem. And what we found was that when people had to convert from gains to losses, they could solve the problem quite quickly. It took them about 7 seconds on average. But when they had to convert from losses to gains, well, now it took them far longer, almost 11 seconds. So this suggests that once we think about something as a loss, that way of thinking about it tends to stick in our heads and to resist our attempts to change it. What I take away from this research and from related research is that our view of the world has a fundamental tendency to tilt toward the negative. It's pretty easy to go from good to bad, but far harder to shift from bad to good. We literally have to work harder to see the upside of things. And this matters.
Okay, so I just thought it was a piece of interesting sort of dialogue, and there's much more interesting research as well off the back of that I've read from the same author, and that could, that could lead to some interesting conversations as well in the future. But just, I think why that's stood out to me and why I was thinking about it is because there's so many positives that are going to come out of what we all went through during the pandemic. A bit like when I lost my gran and I forgot to mention her name, it was Violet, and it's a rule of mine to always say my gran who inspired this project and then to say her name Violet, so sorry gran. It was really important to me to find positives in that experience, and I think just remembering briefly back to that time during 2005, there was so much negative press about MRSA in hospitals. I just got frustrated and I thought, what if we just flip that and we turn that into what are the key messages everyone needs to know to reduce infections when they visit a loved one? So I think there's a similar opportunity here, post-COVID, post-pandemic, sorry. And here's an example of a brand doing
got some safety tips that you gotta know. And trust me, it's something that you wanna hear. So honey, sip your lip and enjoy the show before we move into the stratosphere. Yes, go the boy, it's the tight and keep your in their chair.
Okay, so the question there for me is what game frames in IPC could there be to educate and inspire people? So, where we are, there's a number of things on the left. I won't go through them all now because time's getting short, and where we could be. But this concept of framing things in the game frame, I think, is a super interesting thing for us to discuss at the end. Okay, so this week, this is my final slide. This is my little boy Finn, by the way. And every parent's nightmare, Sunday morning, we were all getting up and I heard a scream, and he'd tripped. We were with him, my partner was with him. I was just a couple of meters away in the bedroom, and he tripped over his feet and he fell 13 stairs down the stairs, rolled, banged his head. And, it was just that situation where my partner saw it, and so she was going into an emotional panic response to a degree, and I had to try to sort of act as logically as I could under the pressure of the situation. So obviously, of course, it was trying not to move him, it was getting on the phone as quickly as possible, and pretty soon we were on our way to the hospital. There were 3 assessments of him. We were kept in for just under 5 hours, and we basically spent our Sunday morning in our pajamas in A&E, surrounded by lots of vulnerable people, and it all happened really quickly. There I was, and so I was pulling on my infection prevention knowledge from 20 years ago, those workshops, but I was also dealing with the fact that he'd banged his head, and he was talking about his eye hurting, the fact that we were moving at pace through the NHS system, and I was trying to make sure that we weren't going to be bringing things in, taking things out. And then, of course, once he's had his assessments, he's wanting to play, he's feeling better, they're monitoring him, and then he's sharing toys with other kids, and he's on the floor, and someone's mopping the floor, and then there's pregnant women there, and there's all these situations, and I was just sort of in an emotional state myself, and I was starting to feel the emotion from it, and I was having to say to myself, okay, I need a little bit of support here. I'm going to lean on AI, and I'm going to put in the variables and I'm going to ask for some IPC knowledge. And it gave me a list, and it started to give me some help to help me structure those next 2-3 hours that we were going to be there from an IPC point of view to protect myself and to protect my family and other people. I then obviously started looking for opportunities for the ward and where I thought they could have potentially had things in place which would have helped us when we came in, including, you know, things like an iPad with maybe a 2-minute video, just bringing those positives. You're here, you're supporting the team. If you spot anything, etc., let us know. And here's 3 or 4 things you can do. And, you know, I was very much in that Doris, you know, moment. I'll call myself Morris. I was a combination of Larry and Morris. You know, I was out of my depth. My family was out of my depth. And then this amazing thing happened. Someone came in to clean the ward in about the first half an hour, and they just were so passionate about what they did, and they spoke with so much like love and affection for IPC. And my partner, who tends to freeze in hospital environments and finds them very daunting, you could see it rubbed off on her, this inspiring voice of someone who loved their job. And I haven't seen this before, but she started doing different things to reduce infection whilst feeling that pressure that she feels while she goes into a hospital. She was bringing through some IP knowledge, probably that hopefully has fallen off from me, but also from this passionate individual. I still find it hard to talk about infection prevention with with a doctor or nurse because it's intimidating. I would hate to think there are any dynamics in there where they weren't doing things that they could have been doing. But as a trained person, not as a trained person, as a person with a passion, I felt like I had some qualification in there, and that's my passion. You know, that's my hope for the wider population. So, you know, is there an opportunity now? I spent the first half of the year working in digital inclusion. There are millions of people with very low digital capability in the country, and access to technology is a massive problem. The government's just launched a new digital inclusion action plan that's throwing money and tackling this problem from a national level and across different regions. I've been out running workshops with people in my local community, and it would just be great to sort of have a conversation to see whether there's something that, you know, can form coming out of the back of the pandemic, where we take what we've all experienced and we find a way to have some form of, you know, IPC action plan for the public, because I feel like those dynamics can improve in pressured hospitals if the public are bringing a lot of the basic skills. Imagine if everyone in the country had a you know, a bit like a cycling proficiency certificate where they learned 5 things at school, or they learned 5 things at their workplace that they could take in to help reduce infection. I could talk a lot more. I'm aware of the time. Thank you very much to Phil and John and to everyone for attending. Mrs. Jell and Friends is trying to play a role in this moving forward, whether it's character creation. We're writing some storybooks. We've got a number of things where, and the next decade is really about trying to work with teams and environments to bring, you know, data-backed educational resources to environments and to digital and to AI and tools to help, you know, help in multiple ways to reduce infections. So thanks very much.
Thanks very much, Alastair. Really enjoyed your presentation. And well done on trying to get through that paper as well. It's definitely a challenge if you're not used to reading scientific literature. I think John and I, because we read it all the time, you're familiar with the layout and what you're looking for. And ChatGPT is amazing, isn't it, for doing things like that. But yeah, really enjoyed your talk, and really admire kind of the emotion and the personal experience that you brought to it as well. So tell me a little bit more about Mrs. Jell and Friends, and you know, have you seen any? You talked about some of the work you've done originally and the impact that made, but what's the kind of the next steps, and how can you apply some of the things that you've identified through your own personal experiences and bring them into learning for other people?
Well, the big question, and I'm lucky enough to live in the southwest, and we've got love him or hate him, we have Dyson right near us, and I've followed that story since I was about 16 of how he took a problem and he worked on it for a long time, and then he had one product and he wanted to solve problems, and the Dyson story is all around us here in the southwest, even to the fact that one of his family members lives nearby, and the helicopter flies over regularly. So I'm passionate about solving problems and moving into like the product space at the right time, and whether that's and I feel like that should be an entertaining, engaging, hand gel bottle range. I don't know if you can still see the characters, but making Mrs. Gel and Friends, or working to build Mrs. Gel and Friends, so it can be sort of something that feels like Sesame Street, or Bluey is another successful global brand, and things like that. And I put the chances at that sort of level about 5%. But if there's a problem to be solved, people need to be educated. How are we going to do it? We'll need to do it in ways in which meeting Doris and their children and their families at their stage, and working backwards. So, things like on the physical level, hand gel bottles that make children want to run up and gel their hands. Bottles are the right height for families and children, and for people who might have mobility issues. Using AI and photography of wards, hospitals, toilets, and communities, healthcare centres, to use AI to say, how can this environment be improved? Where can we put soap? Where can we where can we identify that there will be risks? Toilet seats, things like that. Products that make this subject something you want to engage with and feel entertained by, not just always talking about infection prevention, a world that these characters can inhabit that feels as normal as Soup Potato, which I've struggled to pronounce, and other character brands like that, that also has the IPC message interwoven and tagged on. And I think, bringing partnerships are really important, because being outside of healthcare is difficult. You can have all the cartoon characters in the world, all the goodwill, all the sort of emotion and the desire, but ultimately then you do need environments in which you can do testing, work with local universities. We've got Bath University here, work with universities to do research projects. So, at the moment, for me, it's about trying to finish our first series of storybooks, so that we've got a physical product that can go into the right places, so people can, feel supported around infection prevention messages through stories. That's something I'm working to finish by sort of January, February, so they're physical products. Licensing the products to different organizations who may wish to use them. We've got a conversation going at the moment with a children's ward, where they're doing a redesign and looking at ways in which the characters can support infection prevention and just well-being in those environments. That's something else we're working on. But more long term, I would love to sort of bring a bottle to the market that's educational and links up a few of those subjects and gets children really wanting to lean in to this subject.
Sounds like a really promising way forward. I think a lot of the things you identified are challenges that I've observed in IPC, whether or not it's the human behavior side of things, or it's the messaging and how we communicate things to the public. I'm actually down at a conference at the moment in Bournemouth, and there's been quite a lot of talks talking about the language that we use within IPC, and John actually presented talking about how you approach a patient on, trying to get a sample, or taking a sample to detect whether or not they've got a certain multi-drug resistant organism. And the language that you use to kind of engage and increase that compliance is really, really important, because if you start using words like carbapenemase is the example that John gave, which is an enzyme which breaks down antibiotic, people immediately switch off because they don't understand and they don't follow, and they feel nervous. Whereas actually, if you change it into a way and a format where you can educate them a little bit more about why it's important, and why we want them to be able to have the test and the benefits for them and others around them, then it makes a real difference. And I was really interested to talk about some of your own personal experience that you reflected on, and I think it's definitely a challenge that we face within IPC about how we educate public and how we think about keeping people safe. And I really like the analogy you use with the airline as well, and I think I would feel exactly the same if they told me to put the window blind up so that we could see if the engine was on fire. I guess the other thing that I wanted to talk to you a little bit more about was just kind of trying to get your opinion on like how we break down some of these barriers that are there. So I think a lot of the things that you're talking about is trying to make the messaging simple and clear and fun, and a lot of this is going to resonate with children, but how does it resonate with adults as well, and how do we ensure, because I think you need the parents buy-in a lot of the time, and a lot of it I guess your own personal experience is about instilling those behaviours in your own family. But how do you think, these messagings can be portrayed in a way which captures the whole family? Cartoons are great for children, but how do we get the buy-in from the parents and the adults as well?
Well, good question. And I guess it depends on the context. The other day when we were in a kind of semi-emergency, and Finn's fine, by the way. He was sort of chasing his balloon within a couple of hours of getting home, and he was okay. But in that situation, it was it took me about 2.5 hours to think about infection prevention from the moment he fell down the stairs, and I was already been in the ward for an hour and a half because of all the different things going on and all the things I had to manage. What helped us, and like I said, my partners particularly find it very difficult to go into hospital. It's just a very triggering place for her. What changed it for us was the joy from the person who was cleaning the ward, and how he spent the time, a few minutes, telling us how much he loved to be part of the healthcare, system. And we sort of froze in time, and to watch someone talk about their passion, keeping people safe, and to put it into context. I mean, I do think that was the moment that changed my partner's relationship with infection prevention, because she started taking out Clinell wipes and cleaning stuff in the hospital for the next people. Oh, he's just touched this, he's touched the toy, let's
Right.
She wasn't using phrases like let's break the train of transmission, but I know toys are a big risk, and kids, and she was doing things that no one had told her to, but something changed in her brain. In that case, that was an inspiring story, or an inspiring person. And I think, it helps to feel inspired. And secondly, off the back of that, the pandemic was difficult for so many of us. I actually felt very confident. I wasn't going out every single day into the world, but because I had a number of IPC skills that I'd learned previously, I was going out and moving through society, utilizing those. And I went to one of the conferences in Liverpool, the annual infection prevention conference, and one of the infection prevention nurses said on one of the talks, we knew how to keep people safe. We could have had people come in more to the hospital to visit their loved ones who were critically ill, because we knew the steps to teach them so they could go and safely view their loved ones. And that might not have been true throughout the whole pandemic at the beginning, but this idea of it's knowledge is power, and that's why one of the reasons I'm so passionate about this subject, because the more you learn, the more sort of power you've got as you move through environments, whether you're a visitor or a patient, or to have an adult conversation with someone who might intimidate you, which might be a doctor or nurse. If you can actually talk to them in their language and build that language up, that's really good. But to start that, you have to have some level of lean in from the healthcare system. So that might be more, passionate stories from people who actually keep us safe. That might be, top-down national programs. But it's such a big opportunity. I just feel like it's such an opportunity, because I think the public would be listening if the messages are delivered correctly, because we've all lived through a pandemic and we know what that means. We know how much of our lives. So I don't think it has to be over complex. For adults, it might be that, it comes through, the messaging comes through adults, but adults, kids sit down with their grandparents and their parents and watch cartoons. So
yeah, I think it's sorry, just somebody came into the room. I think it's about a lot of those things that you described. I think a lot of the time as well, we talk about leadership in IPC, and I think that example you gave about, the cleaner who was talking about being passionate about their job, and kind of how that gives that security, and breaking down some of those barriers as well, just by having a conversation with somebody that's passionate about what they do, and encouraging you to feel safe in that environment is probably really helpful.
Yeah. The other thing to say, Phil, as well, is we get on a plane and we're given a safety. We're given the equivalent of the IPC up front. There's no choice around it. So sit down on the plane, cards in front of me, video comes on, and then there is the display. There's the sort of cabin crew do the display of what we're supposed to do in the event of an accident or an issue. I can just park at the car park and walk into a hospital, can probably get quite far around the hospital, and there's signs, but there isn't the boundaries and the barriers. I can become you know, the person carrying on something I shouldn't, or the person not, you know, drinking away. I can just do that. There isn't the requirement. There's nothing stopping me. And I know that's an obvious thing to say, but actually in that ward, what I needed was a whole bunch of iPads, one that says used, one that says, you know, clean. And we lift it out because we know, because we've been shown at school, that when you get into the children's ward, there's a training, you know, system, and it's your responsibility, or someone gives it to you before they, not before they check you in, obviously, but there was quite a lot of waiting time before we were seen. And we watch our little video, we select our language, maybe we select, you know, watching it for parents, and there's the passionate cleaner, or, and then for Finn, who's sort of, you know, can speak, but he's just under 3, we've got the video there, and it's got, you know, audio titles, or it's got it delivered in a different way. And we choose, but we've been given our safety briefing in an entertaining, informative, engaging way. And we're kind of semi-trained, so we've never had IPCC before, but we're in those wards and everyone's, there's like a whole bunch of things that aren't right, you know. And in the end, you know, after 2 hours, you know, the decision was made. My partner's actually going to go and sit in the car because it's safer for her to be out of this environment from an IPC point of view than to stay in it, because now there's children throwing up, there's all these different things going on. But yeah, there's so many quick wins. There's so many quick wins.
Yeah, definitely. Listen, Alastair, it's been really great to talk to you, but we're at time. So just a big thank you from John and I and IPC Partners for coming on today and sharing a really personal story. Just to finish, John and I, through IPC Partners, have launched a new function on our website, which is Learn With Us. We're putting together quite an exciting program of journal clubs and now webinars for next year. So please scan the QR code to have a look at that. We've got 2 more journal clubs before the year is out. We've partnered with the Infection Prevention Society for our next journal club, which is a week away. So that's on the 10th of December. That's all about making change happen. And John and I will be going through 2 papers there to talk about change in IPC. And then John is going to our last journal club for 2025, which will be talking about an economic evaluation of enhanced cleaning and disinfection, which is based on some of the work that Brett Mitchell has done in Australia. And as always, you can see all of our recordings on our YouTube channel, and you can check out the website for more information. So Alastair, once again, thanks for coming on, and thanks to everybody who dialed in and listened, and we'll see you on the next one.